The first annual Riordan IVC and Cancer Symposium proudly presents Should Nutrients Be Added to the Basic IVC Formulation? Your presenter, Vivienne Matalon, MD.
First of all, I've been having the pleasure of working with Ron over the course of, I guess, about 9 years, and accidentally stumbled onto intravenous vitamin C. As a patient, kind of forced me into the integrative arena. And in so doing, I was lucky enough also to be lectured by Dr. Riordan and then get some additional lectures. And one of the reasons I got into this, like many of us, is that the nutritional profile of the cancer patient was something that was being neglected. And really, this is more a talk on the additional nutritional support of a cancer patient. Because up until recently, most of what we had been focusing on was cancer therapy targeted with chemotherapeutic agents. And the patients, as has already been discussed here, would end up in infection problems and would be immunocompromised, but nothing collaboratively was really being done to support the nutritional immune system of these patients. So I'm going to talk a little bit about, IV nutrients and their ability to support the immune system. And what they really are, they're really these admixtures. And as we add them to vitamin C, they're really any structure in the IV bag that's not made of water, basically. Hopefully for additional benefits, obviously varying in composition, and they can perform more than one function. There's different forms of admixtures. They can be either chemical or they can be mineral. But you do have to have some degree of caution when you add an additive to your IV bags. In particular, the addition of electrolytes, trace elements, and vitamins can all cause precipitation. So this can be due to physical incompatibilities and chemical degradation of individual ingredients. There's a lot of causes of precipitation. One of them is excess calcium phosphate. Chemical instability can occur because of the result of oxidation and the precipitation of trace elements. This can be caused by the formation of iron, phosphate salts, or even copper cystinate. In cysteamine, also containing amino acid infusions, this can occur. It's important to remember that, ascorbic acid, even though we're using it very safely, is also a least stable nutrient. And it can react with oxygen, and it's catalyzed by copper ions. Where's this oxygen coming from? Simply being, it's coming from our nutrients that we're putting in there. These are your parenteral nutrients. Even your filling process can affect the oxygenation content in your IV bags and the air remaining in the IV bag after filling and the permeation through the IV bag. So what can you do to reduce the instability? Storage in multi-layered bags. This can reduce the gas permeability and protect the residual ascorbic acid. Other chemical losses can occur by sulfite, which causes reduction of thiamine. And also photodegradation can occur. Photodegradation can affect different vitamins, particularly retinol and riboflavin. Okay, so we're all using vitamins. We use them orally, and in this context, we're going to talk about using them intravenously. So vitamins are really a heterogeneous family of drugs. They have different molecular structures. Now, when we talk about cancer patients, who is deficient in vitamins? Well, they all are, and they all need vitamin replacement. Many of you are familiar. This is the Myers cocktail. It's combination of vitamins and minerals. It contains magnesium and calcium with B6, B5, B12, the vitamin B complex itself, and vitamin C. Just wanted to put that up so people had a familiarity with that. And I'm going to give you a little breakdown of just some vitamins that I use in IV vitamin C. B6 or B6 vitamers are actually naturally occurring pyridoxine derivatives, and they come in actually three forms, as pyridoxine, pyridoxylaldehyde, and pyridoxamine amines. The form that I use intravenously is pyridoxine hydrochloride at a concentration of 100 milligrams per cc, and as a 2 cc per infusion. Now, I just want to clarify one thing as I go through the vitamins. With the exclusion of glutathione, all the vitamins are actually added beforehand. And I have put on, just for each slide for you, the amount in cc's per infusion. To calculate this in terms of B6, 25 milligrams per kilogram is considered the tolerated dosage. You do have to be careful of side effects, though, because B6 can cause paresthesias. Some patients can experience somnolence. In particular, too, this is not just with B6, but any of your intravenous vitamin C patients, we do try to encourage that they have a protein-enriched meal prior to their infusion and that they are well hydrated during the process. Also, you should note that there can be interference with B6 in patients who are taking levodopa, which is cinnamon. So what are some of the benefits of B6? Well, it has been shown to reduce the risk of colorectal cancer and to lower stress markers and to reduce inducible nitric oxide by nitric oxide synthetase protein and suppress the tumorigenesis by, one, reducing cell proliferation and reducing oxidative stress angiogenesis, which has been discussed by many of the doctors. B-complex vitamins, we use a 2 cc per infusion, and it's a group of water-soluble vitamins that we use, which is B1, B2, B6, B12. And these are the components, and they're acting as coenzymes. There are other components to B-complex which we are not adding, which is nicotinic acid, pantothenic, and biotin, lipoic acid, and choline. B6 deficiency is important in patients with cancer. It can cause a pellagra-like dermatitis, ataxia hyperacusis, which is a type of hyper-irritability of the hearing, hyper-irritability, glossitis, reduced alertness, abnormal head movements, convulsions, and can be associated with high homocysteine levels and chylosis. Vitamin B1 or thiamine, pyrophosphate, do not use this. It is associated with anaphylaxis, and we do not use this in our infusions. Vitamin B5, pantothenic acid, dexpanthenol injection, 250 milligrams per cc. The main precaution, and this again is a 2 cc infusion, main precaution is that it can prolong the effect of succinylcholine. Vitamin B12. Vitamin B12 has, three forms. There's cyano, hydroxy, and methyl cobalamines, and as a 1,000 milligram per cc concentration, we use 2 cc's per infusion. We do give B12 supplements also orally, but the orals have really been discussed just now by Dr. Cryer. B12 deficiency is really an extreme problem in patients with cancer. It's been shown by researchers all over the country, but in particular one study by Johns Hopkins found that women with breast cancer had as much as a 40% depletion of B12 in comparison to women without breast cancer. Also, pernicious anemia has been shown in patients who have been gastrectomized, as much as 50% in gastric cancer. It has been shown to be a problem in post-XRT in patients with bladder cancer. And the highest risk of B12 deficiency still is postmenopausal women. Zinc. Zinc's been shown to be protective for the prostate from early damage, which can lead to the development of cancer. Epidemiologic studies have shown that zinc deficiencies have obviously increased risk of cancer and can correlate prognostically when determining the chance of a patient reaching remission, especially pre-chemotherapy. Zinc has been shown to overall increase the clinical course of the general population condition of cancer patients, and we use a 1 milligram per cc and 2 cc infusion. There's several different trace minerals that we use with our IVs. We use chromium, simply put at 8 milligrams per cc at a 2 cc per infusion. Selenium, 4 milligrams per cc, again 2 cc's per infusion, and God bless you. And magnesium chloride, 20 milligrams per cc at 5 cc's. You should note that there are contraindications with use of magnesium chloride, especially the patient with heart block and renal impairment. And you should be monitoring patients' renal function. We do it at a Q2 week interval. I'm going to take questions at the end. Calcium gluconate.
Can you use a magnesium sulfate instead?
Yes. Calcium gluconate, 93 milligrams per cc, 2 cc's per infusion. Okay, the gluconate salt of calcium can be chemopreventive for colon and other cancers. And this has been published in the Journal of Clinical Oncology. Calcium gluconate's been demonstrated in a reduction in neurotoxicity, and that has been caused by oxaliplatin in patients being treated by and for colon cancer, colorectal cancer. Taurine. The concentration we use is 5 milligrams per cc at a 5 cc infusion, and this 2-aminoethane sulfonic acid is a conditionally essential nutrient. It's it's not well discussed, but it actually regulates genetic transcription, and it acts as a neuromodulator. And actually, we've found that it really made a big difference for patients as a potent cellular protectant and immune enhancer. It has had studies that shown extended survival time of cancer patients, reducing the interleukin endothelial cell cytotoxicity. Calcium homeostatic mechanism important in anti-cancer functions, and tumor cell growth reduced with the addition of taurolidine in intraperitoneal tumors. Glutathione, this is the one nutrient that we use and is added at the 1/2 last portion of the infusion, and it's added at a concentration of 100 milligrams per cc, and we use 10 cc's. And previous studies have shown that glutathione is capable of detoxifying carcinogens. Cysteine, which is an amino acid precursor to glutathione, you can elevate your cysteine levels and correlate with lower incidence of breast cancer. N-acetylcysteine, a precursor of cysteine, can boost cysteine levels and has been discussed as a chemopreventative agent against breast cancer in the Brigham study. There's a glutathione factor, which is a thiol-containing tripeptide, acting critically in protecting organisms against toxicity and disease. This is really just a brief overview of some of the nutrients that we have used intravenously in our center. Dr. Ron wanted me to discuss them. Yep, that's it.
I just have a question to ask
Yeah,
you.
go ahead.
I will just use the
Sure,
mic here just
please.
first of all, we'll share it.
Yeah.
Is there any concern that the glutathione that you give might be interfering with the hydroxyl radical formation from IV vitamin C?
No,
Not seen any?
not at all. Not in close to 10,000 infusions.
Okay.
Yeah.
And what about another question? And what about some of the B vitamins, especially B12, being this plastic tubing attached?
No problem.
Not seen.
No. Yeah, I discussed that with McGuff, and they said that, this was not going to be a problem, and I tested it out over the course of the time. We've never had a problem.
Okay. Come to the microphones if you have questions.
Question on
Let's just tap on it. There you go. Bill.
Just a question on your selenium. Was it milligrams or micrograms? Because
Yeah, it was-
you said milligrams up
Yeah,
there.
it was milligrams, but it's micrograms.
It's
Okay,
micrograms, that was a typo.
Because that could be toxic.
I'm
Yeah,
sorry,
you
that's
bet.
a typo.
Yeah,
Thank you.
yeah.
It was the same question about
Yeah.
vitamin B12. Is it milligrams or micrograms?
It's
Micrograms.
micrograms.
Yeah,
I think that they had a couple of typos.
I'd have to look at it,
Yeah.
Okay, Garrett? Go ahead.
Yes, regarding the glutathione you added to the vitamin C,
Right.
how did you know it wasn't interfering with the hydrogen peroxide production?
You know, that's, how do we know that it's not
I mean,
interfering?
you said no, it's never caused a problem. You said in all the patients we've done.
Have you, question is, has it interfered, but have you noticed any change in outcomes as a result?
No.
Was there ever a time when you weren't using the
No,
glutathione?
Always used it.
Always used
you've
glutathione.
never
How
had-
many in the room just use glutathione infusions with their IVC? Several, okay.
Always used it.
Okay.
Yeah.
I mean, there's a conflicting views on this, and this is
Actually,
just
This is from ACAM's protocol.
from ACAM's protocol
Yeah.
for, okay? Yeah, she did, yeah.
And then also selenium not included in the vitamin.
Okay.
Yeah, that'd be good.
All right,
That'd be
that's good.
Go ahead.
Okay.
Again, concerned with degradation, in this case, but cobalamin is highly photosensitive, and the package of the IV being transparent, well, that is, I've seen in some hospitals, they yield to our request, I'm sorry, of giving B12, but then again, the curtains are wide open, it's really unstable on photosensitive B12. So do you?
I think that point is controversial.
is?
And, yeah, and I really think that at this point, I have not seen any evidence that it was a problem.
Okay.
Yeah.
How do you measure that? I mean, it'll take really profound studies to.
Well, I'm actually not making the recommendation. I mean, I'm taking recommendation from ACAM and from McGuff. The
Okay.
pharmacologist from McGuff, actually, we discussed this at length.
The photosensitivity.
Yeah.
Well, we'll look at.
It's a similar question with just vitamin C in the bag out in the ambient light, and one of the things that Dr. Jackson has taken upon himself is to do a study of what happens depending upon how long the bag is out and after you put in the vitamin C, because you may be losing some of your effectiveness that way.
Yes, there's a physician in Puerto Rico that claims that using infusions in a crystal bottle, a glass bottle, makes a big difference. However, I don't have a point of comparison, and I wonder, being here in a big audience, if somebody have had an opportunity to make that comparison.
How many people use just the plastic bags for their IV infusion? How many people use the bottles? Okay, any problems?
If you mix it up and let it sit for a
Oh, yeah,
while.
that does matter.
Why don't you mention?
Yeah, absolutely, that does matter. Yeah, you should mix your IV as soon as you can to use. Yeah, for instability.
Oh, well, that's another issue.
Can I talk?
Yeah, go ahead.
We treat chemically sensitive patients in our clinic, and we have used glass for years. And lately, we haven't been able to get it, and we've been starting to use plastic. And we do find that some of the patients don't tolerate the plastic, even if we mix it up right away. So I think it just depends on the patient. And so if you have a patient that says, I feel sick as soon as you start the IV, they're probably reacting to something in the
Phthalates
plastics.
in the plastic. Yeah.
And so, maybe those patients could use glass, but, yeah.
Yeah, I think we need those studies. Yes, go ahead, sir.
I was just going to say, as far as the glass versus plastic has been well known for a long time, fat-soluble vitamins adhere to the plastic more so than glass, but as far as the differences in general intravenous therapy, I don't know, but that's well known, and that may be what they were alluding to is fat-soluble versus water-soluble. What I wanted to bring up is that I was trained that when you're using the ascorbic acid therapy for cancer, if you're, as we've talked a lot about today, a pro-oxidant approach, there's probably a lot of other things occurring. And so you want to try and maintain as much antioxidant support separate from the intravenous IV or the vitamin C. And then you do a kind of like a chemotherapeutic day with high-dose vitamin C, and then you do another IV with nutrients. That's kind of the old way that I've been practicing. I've been talking to some of my colleagues that are not really seeing that much of a difference by combining all of them. And I've used both. And I don't know which is better, but it's a hot topic in combining things like glutathione with vitamin C. Personally, I myself have my nurses push it at the end of the IVC.
We give it at the latter portion also. Yeah, we give it also at the latter portion of the IV.
Just out of curiosity, how many people follow that kind of a protocol where you have a kind of a nutrient day where you give more of a nutrient IV as opposed to the higher dose IV vitamin C for the chemotherapeutic effect? Yeah, okay. Okay.
Well, you know,
Garrett?
that also goes hand in hand with when you're doing chelation, because at that point too, you're giving lower nutrients too.
Mm-hmm. Same sort of thing. Michael, go ahead.
Just curious, a question that I don't know the answer to. Is there anything in the literature about any of this stuff, giving a number of IV nutrients to cancer patients in terms of, there isn't, is there? Anybody see anything?
There are some that are out there that I've seen, and
we produce TPNs for short bowel syndrome patients, and I mean, next to fat, protein, and sugar, we frequently use MultiPlus, which is a multivitamin mineral product, which is injected right before TPN onset, usually at bedtime. And those are not orthomolecular doses, mind you, but they are intravenously used continuously and every day, because these patients get usually 5 doses or up to 7 doses a week. Every night they get hooked on.
Yeah, I'm familiar with the TPN part of it, which is really the nutritional support of the patients. But in terms of whether or not adding the nutrients to the high-dose vitamin C is going to be beneficial or not, there's really no literature on it.
I don't think it's been clearly studied.
No.
Okay, Garrett?
I know there is at least one study out there. I thought it was with cell culture, where they looked at the vitamin C cytotoxic effect, and they used, I'm almost positive it was the N-acetylcysteine that they put in there, and it blocked the cell-killing activity. So is that the right one?
I'm not aware for sure. I don't know if anyone else knows that
I'll have
reference.
to get that study out, and maybe I
Yeah,
can
that'd be
email it to you.
good to know. Yes, ma'am.
Is there concern with the of anaphylaxis with the B1 that's in the B complex?
Is there, concern?
Extremely rare.
Just because, it said that we should not use B1 directly, but there is some in the B complex.
Right, no.
Is it that the amount
Never
is
had
too
a
small?
problem.
Okay.
No. Michael,
Okay.
you use B complex also.
To the microphone.
Yeah. Sorry.
Okay, a couple more questions. Come to the microphone so that we can hear you. There we go.
I just had a point that I forgot to mention as far as the light-sensitive. McGuff does provide light-sensitive IV infusion kits as well as covers for the bag. So it is something that's...
He's saying that McGuff does provide light-sensitive infusion kits.
Light resistant.
Yeah.
Yes, Mal.
Are you using lipoic acid in your infusions?
Okay, come on, yeah.
Just a point of reference, if anybody is going to be using lipoic acid with vitamin C, you cannot mix them together. They will precipitate. You have to use them sequentially in some way, yes.
How do you do the lipoic acid? Tell me how you do it.
I did it, and I don't do it anymore. I mean, I'll tell you, our experience was that I started doing it. I was doing it a little differently. I would use the C, and then I'd use alpha lipoic acid. And it sounds like some people think it's better to do the alpha lipoic acid than the C. But anyway, that's how I was doing it. And we did it for a couple of months on most of the patients.
It was more expensive, obviously. It seemed to irritate the veins more than the vitamin C, so people were complaining of that. It would take longer, and I couldn't see any absolute significant benefit, and so I just stopped it. So I'm awaiting somebody to do studies to show me I should be doing it.
Yeah.
Huh?
There are studies.
But you think you give
Showing that okay, get up and talk about it. I don't know the studies.
It's the whole German study from Meda Pharmaceutical or Asta Medica previously. You have very well done studies, and you have your own man in California, David Carlson, who did organochemist, who did excellent research on lipoic acid. And the German protocol is mentioning that IVC is given either in saline, 100 milliliters of saline, IV drip, as Dr. Godin does it, or an IV push, strictly specifying that slow IV push is 12 minutes, not less. So it's lipoic acid, but they use tromethamol salt, sodium salt, or EDTA salt of lipoic acid.
And what did the study show?
Well, I will send you the study. It is used, yes, I mean, Bert Bergson has spoken about that so much. I mean, I'm not the expert, I'm just a cook. But the thing is, I mean, it's very well documented, and I can send you a paper, and in diabetic neuropathies, it's very well researched, and Dr. Miranda also.
No, but I'm not talking about with cancer patients. I'm talking about. I'm talking about the vitamin C plus lipoic with cancer as improving.
Well, that's what you are talking here about. I mean, you have the most experience. We are trying to learn from that, but I know the use.
We do not use the alpha lipoic acid. And here at the center, we've kind of maintained a rather simple and strict protocol just to try to clarify our minds here, but we are interested. Part of the reason for this symposium is to bring in what other people are doing to see what kind of results they're getting and if there should be research initiatives started in these particular areas. Dr. Gordon, yes.
I just want to contribute a thought. The FDA is starting to get their nose into the doctor's medical practice in our state.
Starting?
Yeah. They're very concerned that what we are doing is compounding, and that we're turning our offices into compounding pharmacies.
Yeah.
And the scuttlebutt is that they're going to really come down unless we all have hoods, and we do this under sterile hood. So I want to bring everybody. The point of making that is that I think what Michael Schachter was asking, do we have documentation showing that if we do intravenous lipoic acid, is there enough bang for the buck that I should be doing it intravenously, recognizing that every time I do something intravenously, there's the remote chance that there's some coprecipitation. Many things happen. And I'm so glad you mentioned never make up these IVs the night before. This is not good medicine.
Gary, probably not at this time for the answer to that question.
And so what we're trying to look at is if you can get the bang for the buck by K3 orally.
Yeah,
And if you can get the bang for the buck, and Bergson's my buddy, but I've looked at everything about it, and I think usually the lipoic acid is doing most of what I needed on the oral. And I'm trying to simplify it, because if we get 10,000 doctors doing this, the more that join us, they're going to look for any ways to stop us.
Right. And I think your point is well taken. It has to be safety first.
Thank you. That's all.
Okay. Garrett, yes. And then we're going a couple more questions, sir.
I did find that article. I happen to have it. It was
You're a good medical student, you know.
Virax and Calderon out of Belgium did some studies on IV vitamin C last summer. It just came out in Free Radical Biology and Medicine. But they did add some different things to the infusions. Catalase obviously blocked the cell killing, but also N-acetylcysteine did too, which makes me a little cautious about using the glutathione, because being that it's a prodrug for glutathione production.
Yeah,
But
I think it needs
it
some more
hasn't been
research.
It hasn't been looked
Yeah,
at
that's
specifically.
needs research. Thank you. Well, last question.
Yeah, hi. I just want to share with my clinical experience with using lipoic acid IV. Like when you're in the trenches, you're always trying to help people out as best you can. And so vitamin C, lipoic acid started getting popular. There was a case published in one of the journals with, I think, Bergson and Rubin, I think it was, using lipoic acid with naltrexone and pancreatic cancer. So then I was like, okay, well, let me try to start using this kind of stuff and see what happens. And this is what I noticed with it, is when you get to a certain dose, about 300 or 600 milligrams, you can actually induce this really strong chill about 2 hours afterwards. And when you look at the drug write-up on it from Germany, they say that that's a side effect, right? And what's fascinating about that effect is that in patients who don't have some serious diseases, they don't get that chill. So then on one of my patients with metastatic breast cancer, you know, her cancer started to grow. She had some cutaneous involvement in the mediastinum. We did this chilling effect, and the nodules actually disappeared. So I was like, wow, that's pretty exciting, pretty cool. The problem is, this chilling effect can actually drain you. It's like kind of burning the candle at both ends. And so a patient would be like, I'm so exhausted, I'm exhausted for days, and blah, blah, blah. So then I tried it with, say, like a colon cancer patient who had mess to the liver, and he was getting this chill effect. I'm saying, this is good, but he started to lose weight. And so over, I guess, a span of probably about maybe, I don't know, 20 patients, I just started to phase it out. And that was kind of my experience. So I don't know if you need the chill, but that was a consistent effect I noticed in my patient when you got to a certain dose with it. And whether that means like you're ramping up the immune system or what, I have no idea. But it's an interesting phenomenon, you know, so just to share with you.
Okay.
Thank you.
Thank you, Dr. Matalon.
The first annual Riordan IVC and Cancer Symposium was brought to you by the Center for the Improvement of Human Functioning International, located at 3100 North Hillside, Wichita, Kansas, USA. To learn more about the center and what we have to offer, please visit us on the web at www.brightspot.org.